pleasure to introduce Lisanne Manson from the Netherlands. We've worked together as part of the UPGX consortium and the PREPARE trial, and Leiden University Medical Center in Netherlands has a great setup. So Lisanne is going to tell us about the experience with the clinical decision support. Thanks very much, Lisanne.
Thank you.
Just press a button.
Perfect. Thanks. So indeed, I work at the Leiden University Medical Center. Thank you for inviting me to speak here. And I want to tell you something about our experience with our nationwide clinical decision support system we're using. So first I would like to start with a question, keep it a little bit interactive. So I was wondering, what would you do as perhaps a physician or a pharmacist if during a visit a patient takes her DNA pass out of her wallet? This pass, actually the QR code actually works, so if you're interested, I do think it works. So the card indicates that she's a CYP2D6 intermediate metabolizer and CYP2C19 poor metabolizer. What would you do? So by a show of hands, would you do A, provide individualized drug recommendations, B, dive into the literature and schedule a second visit, perhaps in 2 weeks, perhaps the next day, C, refer to a specialist, or D, ignore the card as you do not believe in pharmacogenomics? I didn't see any hands. I hope it's at least A until C. But I believe and I hope that in the Netherlands most people would actually do A and provide individualized drug recommendations. And to tell you a little bit more about this, I would like you to meet Marcy. So Marcy is suffering from some headache. And she first tries to treat her headache herself, so she gets some paracetamol from the supermarkets. She gets some ibuprofen, that also does not work. So then she wants to go to her general practitioner to get a prescription. So she gets a new prescription for codeine. And codeine in the Netherlands you can only get by prescription and from the pharmacy. So with this prescription she goes to her pharmacist. And in the Netherlands, we have about 2,000 public pharmacies. So these are not just dispensing drugs, they are mostly about medication surveillance, over-the-counter counseling, first-use instruction. And the medication surveillance includes checking the daily dose, checking drug-drug interactions, for instance, a CYP substrate with a CYP inhibitor or a pharmacodynamic interaction, checking contraindications, so if a patient is pregnant or has a reduced kidney function, what do you do? And also clinical rules. And the foundation of all of this is actually, and of all Dutch prescribing and dispensing systems, is a nationwide database that has been existed since 1984 already, called the G standards. This was first used for pharmacists for declarations to insurers. And it includes over 100,000 medicinal projects at the moment. All manufacturers are obliged to provide all details about their drugs in the system, and it's then used by manufacturers, distributors, physicians and pharmacists, both for orders in stock, for drug reimbursements, but also, more importantly perhaps for now, is for prescribing and medication surveillance. And since 2006, also pharmacogenomics is incorporated in this nationwide database. So back to Marcy, she had a prescription for codeine, and information is actually entered in the pharmacy information system. The dose is automatically checked, interactions and contraindications are checked, and at that point an alert is actually shown. So this is what the alert looks like. Unfortunately, lots of my pictures are in Dutch because, of course, our clinical decision support system is in Dutch. But what it says here in red is that the patient apparently is a CYP2D6 poor metabolizer, and that by using codeine there is a reduced efficacy of the drug. And when you look over here, you see A, B, and C. When it's used for cough, there's not a problem at all. But when it's used for pain medication, as in Marcy's case, it is recommended to discuss with the prescriber about choosing a possible alternative. And if an alternative is not possible, it actually says there on C, you can advise the patient to contact the physician or the pharmacist when there is not enough effects of the pain medication. But what you can also see in the red box at the bottom is that you can get additional information. And there's actually a lot of information available. So again, unfortunately in Dutch, but here it says like the recommendation, what it is, but also the mechanism, the clinical consequences that have been found in studies, the kinetic consequences that have been found in studies. It is all available in the system of the public pharmacy, but also prescribers and hospital systems. So how come she got this alert? Is actually Marcy did have a pharmacogenomics test many years prior, and she had a little pause, and she showed it to her pharmacist, and the pharmacist looked at it and he saw that there were actually two genes that were different than normal. Those are the ones in red. So for CYP2C9 and for CYP2D6, Marcy is a poor metabolizer. And the pharmacist decided at that time, which was in 2017, to record it all in the pharmacy information system. And in the Netherlands, this information is actually recorded as a contraindication, and it is treated just like other contraindications. So all the results are actually entered, also the normal ones, so you know that the patient has been tested. And after permission of the patients, these results can also be shared to other systems. So for instance, to the GP or to the hospital. It is possible to share it, unfortunately only after permission of the patient. But this system is actually nationwide because all systems, all prescribing and dispensing systems use the same database. So exactly the same way it also works, for instance, in our hospital. Here you see a patient who is also poor metabolizer for two drugs. And when prescribed nortriptyline, there is again an alert saying that there is a contraindication. And also here you can get additional information about what you should do with this patient. So how come we have all these guidelines incorporated already? That has to do with the founding of the Dutch Pharmacogenetic Working Group already in 2005. After the completion of the Human Genome Project in 2000, they thought, well, now patients will really show up with the pharmacogenomic test results and we better be ready for it. They also thought, well, the results of clinical pharmacogenomic study are already available, but unfortunately at that time the studies had not yet resulted in practical prescribing recommendations based on the genotype of the patients. So the Dutch Pharmacogenetic Working Group was actually found. It was a multidisciplinary group led by a hospital pharmacist called Vera de Neer. And it consisted of various disciplines like pharmacists, physicians, toxicologists, epidemiologists. And the group had actually two objectives. To first develop the pharmacogenetics-based dosing recommendations, but also to already assist drug prescribers and pharmacists by integrating these recommendations into the computerized systems for drug prescription and automated medication surveillance. And the first pharmacogenomics recommendation in the G standard, so the nationwide database, was already implemented in 2006. So this group was founded in 2005, and within a year already the first recommendation was available. And the only way that was possible in the Netherlands was because the system was already there. We didn't have to develop our own clinical decision support system. We could just integrate the pharmacogenomics guidelines in the already existing Dutch system. So the message of the work group was actually that they did perform a systematic literature review for every drug-gene interaction. They scored it for the level of evidence. They scored it for the clinical relevance. So they gave it a score of A to F, and this is actually similar to the scores from the common terminology criteria adverse events, where C, D, E, F correlates to a severity score of the clinical effect of 2 until 5. And then after that, they decided, is this a gene-drug interaction, yes or no? And is there action required, yes or no? And if so, what action? And only the drug-gene interactions with yes, yes, so both an interaction and there's action required, actually were incorporated in our clinical decision support system. So another example, meet Karim. He's suffering from chest pain, so he got a stent inserted and he was started on once daily 75 milligrams of clopidogrel. But as soon as he was actually admitted, a CYP2C19 test was requested and blood was withdrawn for this. That same day, Karim was already discharged from the hospital, but he received a call from his cardiologist that he should stop his clopidogrel and switch to ticagrelor. So, what happened here? Actually, in the Netherlands, prasugrel and ticagrelor were first choice after stent insertion because they are more effective in preventing clots than clopidogrel, but they do have a higher risk of bleeding and they are much more expensive. So clopidogrel is only about 30 euros a year, while the others are about around 1,000 a year. But then the popular genetics trial was performed, and this was performed mostly in Nieuwegein Hospital, but also some other hospitals in the Netherlands and 2 other countries. And it involved 2,500 patients, and this trial actually concluded a genotype, a CYP2C9 genotype-guided strategy is non-inferior to the standard treatments, but it actually results in lower incidences of bleeding. And because of this trial, now in our hospital and also in some other hospitals, it is now routine that we are using a CYP2C19 guided strategy for treatment. So how and where are these pharmacogenomic tests performed? We have about 16 accredited labs in the Netherlands, of which some are bigger than the others. And all these labs, they genotype both for their own patients, but also for other hospitals or for general practitioners, for pharmacists. And they usually need blood or saliva, and the test results are actually returned within 1 day to about 4 weeks. And it actually depends on both the lab, but also on what test you request. So for instance, the CYP2C19 test we do in the LUMC, we now perform that every day, every working day, on request of the cardiology department, because they want the result as soon as possible. And the numbers we get are then high enough for us to make it profitable. So how does this actually work? So first we perform the test, of course, and then we record the results of the pharmacogenomic test in our laboratory information system. And what you see here is that for this test we do quite a small test. We also have a more elaborate one, but for the cardiology we just test 3 different mutations. We record the results of the mutations that get automatically translated to the genotype and the phenotype, and then to the recommendation. This is all done automatically, and again, this is based on the Dutch Pharmacogenetic Working Group guidelines. The results are then automatically also shown in the lab results of our electronic health record of our hospital. But one thing we still have to do manually is actually to put it into the contraindications. And that is really important, because only when it's the lab results are in there, the clinical decision support system actually checks for interactions and checks whether no substrates for this gene are prescribed. And as soon as it's in there, again, you get these pop-ups. So here it says that an alternative or a higher dose should be chosen, and that was why Karim was called by his physician to get an alternative drug. But what you also see here on the top is that there's actually another contraindication alert, and that's because the patient was also prescribed another CYP2C19 substrate, pantoprazole. So you do see that by different colors, the top one is orange and the bottom one is red, we show which is like the more severe interaction than the other. Because we can't, without a permission of a patient, share the results to other systems. We just send an email or a letter to the one who requested the test when it's an external person. And of course, in the Netherlands, we are using the Dutch guidelines, the Dutch Pharmacogenetic Working Group guidelines, and not the CPIC guidelines. And we have checked whether these guidelines are the same or whether they are very different. And in general, they are very the same in allele classification, genotype to phenotype translations, and also the dose recommendations for most drug gene pairs. But one thing where the Dutch guidelines actually go further in is the clinical implication score. So this is an example of clopidogrel, and the clinical implication score actually is a score that advises us whether we should implement this test before starting the drug or not. So they're looking at different criteria. So we're looking at the severity of the effects, the level of evidence of the drug-gene interaction, the number needed to genotype in the Dutch population, but also the information available in the summary of product characteristics. And in the end, each drug-gene interaction gets a score of 0 to 10. For clopidogrel, the score was 8, and when the score is 6 to 10, it is recommended to test this gene before starting the drug. So you see here that we have 3 different scores. Only the actionable drug-gene interactions from the Dutch guidelines are scored. So they are either potentially beneficial to genotype before starting the drug, beneficial, or even essential. The guidelines, the Dutch guidelines feel that for the essential drugs, we should genotype the gene before actually starting the drug. So some examples of drugs is actually the fluoropyrimidines, and indeed in the Netherlands we genotype. It's routine to genotype for the DPD tests, but also CYP2C19 for clopidogrel, HLA-B for abacavir, and TPMT for the mercaptopurine and azathioprine. And most of these tests are also routine in some hospitals or actually nationwide. So as you can see here in this graph, this is just the pharmacogenomic testing we do at our hospital. We see a steady increase over the years, and actually since this year we started testing for CYP2C19 more and for UGT1A1, and we see an even sharper increase. So in the Netherlands it's standard to treat or to test patients for DPYD and UGT1A1. This is actually done in, to my knowledge, all hospitals. But also nephrology patients are standardly genotyped for CYP3A5. Psychiatry patients who come for ECT are tested for CYP2D6 and CYP2C19. And also, the CYP2C19 test for clopidogrel is done more and more nationwide. But still, we want more. So there are still things that could be better. For instance, there should be a more automatic link between the lab information system and the contraindications, because this is now still done manually, so things can still go wrong. What we would also like to have is the preventive alerts. In our system, we only have the reactive alerts until now, so only when someone is tested, we get an alert. But we would also like to get the alerts when someone has not been tested for a routinely preventive test with a clinical implication score of essential. We should also have an alert that that patient should be tested. What we found out now is that at the moment, like everything, the clinical decision support system is based on the phenotype. So as you saw from our lab system, we do have the results from the mutations, we do have the genotype, but in the end, what comes into the contraindications is the phenotype. We would like to also be able to save that other, the mutations in the genotype somewhere as well, in case the guidelines may change sometime. So, for instance, to have automatic translations that are also updated automatically when the Dutch guidelines updates. And we would also like to have a recommendation on patient level. So I think in summary, we are already very far in the Netherlands, I feel like. Still, things can still be improved. We do have standardized dosing recommendations. They are fully integrated in the workflow. They're available both for prescribers and for the pharmacists or the dispensers. And they're available also both for inpatients and outpatients. So thank you for your attention. And if there are any questions, please let me know.
That's great. Thank you very much. Good to see that it is a health system.
Thank you very much. That's really interesting. Can you tell me what information do patients get, particularly with their DNA card? So what's made available to patients to try and understand the data?
Yeah, actually the DNA card we are not using regularly in the Netherlands, so we're using it in some studies and some hospitals are, but most of the communication is going towards the pharmacists and physicians, and it's up to them to communicate it then back to the patients again.
Thanks very much for a really interesting talk. I'm John McDermott from Manchester. Just wondering, if a patient did agree that you could share their data with other organisations, how is that happening at present? Is it a manual entry into other systems?
It can be automatically done. It's through something called LSP. I don't know what it stands for exactly, but it's the same thing, how we can actually share medication information as well. So it's just with one press on the button, you can retrieve the health records of another patient, mostly like the medication records of another patient into your system. So it can be done automatically.
Can I ask one quick follow-up, if that's okay?
Mm-hmm.
Sorry, Liz. Go ahead.
No, I was just going to ask, it's fantastic to see, it's a brilliant presentation. But I just pulled up the QR code and there's a lot of information in that QR code. And I have to say, as a practicing clinician, I wouldn't have the time to read it.
No, so that's why I showed you some other examples. The card is actually from a study that we're still working on, but usually you just get wait a minute.
Yeah, it's traffic light type.
So you get a really short recommendation, something like this. And only if you're interested in more information, then it is available within the systems. So they have tried to make it as short as possible, and that's
Definitely.
easy to use.
So we just need to move the slides forward for the next talk, but just while they're doing that.
They're doing it. Okay. Sorry.
No problem. So can I ask, let's follow Marcy along in somewhere in the Netherlands. She goes to the Andrew Rio concert in Maastricht.
Yeah.
Unfortunately falls ill.
Yes.
How will the hospital there know that she's got a pharmacogenetic test?
It depends on whether Marcy has given her permission already to the hospital where the results are known, if they can share it. Otherwise, it is, I guess, unknown. But if they are okay with sharing the results, then the hospital in Maastricht could retrieve the results automatically.
So there's no centralized system whereby Maastricht will know that she's had a pharmacogenetic test?
No.
Unless
No,
Marcy gives her...
yeah, so
her
Marcy
consent.
really has to give her permission. It has to do with the privacy
Okay,
rules,
so
of course.
isn't that a limitation for...
It is a limitation.
nationwide
I
care?
think we are working on a nationalized system, but of course there are political concerns about the privacy issues.
Okay.
So it's still ongoing.
Okay, quick question, then we're going to move on. Okay, sorry.
Perhaps I can speak loud enough.
We-
Seamus Leiden, Northern Ireland. Very interesting the way you do it. You have 16 labs that provide the diagnostic. Do they store the data, or do you have a centralized database?
Data is stored at the lab that performs the testing. We don't have a centralized...
Okay, so you're totally dependent on that LIM then, on the lab information system for access to it. Do all 16 labs, are they using the same LIS? the same lab information system, so that you have, because consistency and access to the data must be key here.
I don't think so. So we are using all the same, the clinical decision support system is all the same, and we're using all the same contraindications, but the lab system itself not.
Okay,
But
so it's a separate
like
interface.
All the lab facilities, they just give back the phenotype, and then the physicians or the pharmacists can put the phenotype themselves into the system.
And do you have any plans for a centralized database?
As far as I know, there are no plans, no.
Okay. Because it's a similar
We
challenge
can
for...
maybe take this up later
yeah.
on, if that's okay. So last question, because we need to move on to the next talk.
Do you do the testing in under 18s? And if you do, who gets the data? The parent, the child?
So again, the data is mostly going towards the physicians and pharmacists. They get the data, and of course, the parents can ask for it. And I think depending on the age, probably the child can ask as well. I think it's probably around 12 or 16 that the child can ask for their own information. Yes.
So you're going to be around for the rest of the day?
Yes.
So please ask questions and so on. Thank you very much. You can see there's also interest. Thank you.
Thank you.